going to tell you about is what are the structures when you're treating soft tissue that you're missing. These are the structures that are going to set you apart from every other doctor doing soft tissue. Because anybody says they have arm pain and they're going to come in and they're going to work the bicep, they're not going to think to work the coracobrachialis. So I'm giving you the muscles or the structures you're forgetting. I'm also going to be covering some hip mobility and giving you some exercises. So since this is such a vast field, and I'm going to pop up my disclosure slide so there's no question about anything. Because this is such a vast field and we're in Florida, I tried to narrow it down to the two most common athletes or person that is a weekend warrior that's going to come into your office. And those are going to probably be your golfers and your runners. That doesn't mean you're not going to see a lacrosse player, a rugby player, or soccer player, any of that. But these same muscles will apply to all of those. It's just, Lord knows there's enough golf courses down here, and we know there's enough runners because they're running everywhere, and they're just looking for a good chiropractor. And maybe that's you, okay? So, these are the soft tissue methods that I use, and I am a conglomeration of everyone I've ever learned from and every seminar I've ever taught. I don't advocate one over the other, and if you were to go to my website and look at what I talk about, my attitude is finding the right recipe for the patient. Okay, there's going to be some spinal adjusting because, hey, that's what we do. But there's going to be some soft tissue because something's got to hold those joints where they belong. And this is what sets us aside from the people that are seeing 3 times a week all the time that are just adjusting, adjusting, adjusting. I mean, think about it. Your teeth might be straight after you go to the orthodontist, right? But you put the braces on and you wore the braces for 3 years because the teeth look straight 2 weeks later, but you were waiting for all the soft tissue to get used to holding the teeth in place. So that's what you're doing by treating soft tissue. Dry needling. Usually you have to take advanced certification. Fascial distortion model I only took a few years ago, and where I had this big puzzle of all the different soft tissue techniques I was doing, this filled in the gaps. And if you heard something that I said yesterday about treating the proximal issue tuberosity, I learned that in the fascial distortion model, and I'll cover that a little bit when we get there. IASTM is the instrument assisted. It used to be known as Graston. Graston lost the patent. Everybody else came out with a tool. Find the tool that fits your hands. Find one that's comfortable for you. They are made of all sorts of different ingredients and composites now. Active release technique, that's probably my go-to only because it's the first one I started. But everything branches off of it. So Joe Horrigan was a teacher of mine in one of my diplomate classes, and he showed us some different soft tissue mobilization. So in my notes, I actually chart JSTM. It's just kind of an homage to Joe. I always give credit to anybody that taught me something. Cupping is interesting because everything we do in soft tissue is pretty much compressive. Cupping is distractive. So if you can think of lifting the chicken skin off of the fascia instead of pressing down into it to try to release it, that's the advantage to cupping. Oh, by the way, it hurts. Do it on yourself first so you can find how much suction to do. You go overseas into Asia, oh my God, they'll be like sucking it dry. And you're going, oh my God, oh my God. You do 3 sucks, your foot will cry. The mulligan belt I use for hip mobilizations. I know people use them for shoulder mobilizations. I'll use it for the ankle. But at 5'2", $125, I need to come up with other ways to move the femoral acetabular joint. And I find the mulligan belt is a real nice thing to do. Spider Tech kinesiology taping. Spider Tech is basically kinesiology taping for dummies. In other words, they've got pre-cut forms out there, and if you follow on how to put those up, you can already have them cut. Kinesiology taping of all the other types, you have to go back to kindergarten and remember what you learned there on how to cut, and don't run with scissors. All right, so the 5 most common golf injuries are back pains, you get your strains disc, shoulder, everybody knows rotator cuff injuries, knee pain, stress strain, meniscal tears, elbow tendonitis or tendinosis. If you're not using the word tendinosis by now, I'm going to briefly cover it because I'm not surprised there are some people that don't really know what that means. Itis implies a short-term 3-week injury, okay? So if the patient comes to you and go, yeah, my college buddy came in this weekend and we used to play tennis and we played 3 hours and my elbow's killing me. That's probably tendinitis. Of course, your buddy's still been playing tennis every week and you haven't picked up a racket in 4 years. That's tendinitis. If they come into you 6 months later going, yeah, my college buddy came in and this and that, at that point, it's a tendinosis. The medical doctors are starting to use the word tendinopathy. The bottom line is the joint or the soft tissue has now changed its structure at the joint. And that soft tendon that got inflamed, your body said, hey, you're not going to fix this, I'm going to do it. And what it does is it shortens the tendon a little bit and it thickens it. So now when you go to stretch out your arm, it hurts right at that end of the motion. That's a tendinosis. It does not get treated the same way as a tendinitis. So just so you're aware of that. The lateral is most common. We used to always say tennis was on the outside and golf was on the inside. It's really not that way. It really is, lateral is just most common. Okay, that doesn't mean you won't see it on the inside from that, but you will see both. Wrist issues. Golfers tend to slam the club down and that's how they break the hamate. All right? They also can get their tendinitis down there in the wrist. So anything that they're complaining in the wrist, make sure you clear out the elbow because every single tendon that's down here, the muscle starts up here. So you're doing an incomplete job if you're just focusing on that. You're doing kind of the medical model where it hurts here. Okay, I'll treat here. No, look up the chain, okay? All right, so the structures that need to be treated. In the low back, all right, transversus spinalis, those you pretty much are going to know to do. QL you're going to do, erector spina you're going to do. Posterior serratus inferior you might do, okay? But I know you're not doing the diaphragm. Why do I put those two together? Everybody take a deep breath. Some of you were breathing down here and some of you were breathing up through here. If you're breathing up through here, you now have the answer to why so many of your patients are getting neck pain. Okay, your diaphragm is not gliding up and down as a parachute in the rib cage. So what you're doing is you're starting to use all your accessory muscles to breathe. Watch your patients breathe, have them breathe. I put my hand on their belly, of course you tell them what you're going to do, but you put it on their belly and you have them try to push that up. Think of a baby. Take a look at the way a baby breathes, the way a crocodile breathes. They're all down here. How the hell does Adele hold her notes so damn long, right? That's because she's breathing down here. Your musicians and your singers probably are not going to have a lot of neck pain. Okay? That's because of the diaphragm. So that's something you have to get to. Why do I include the PSI? Because it has diaphragm attachments. All right? Intratransversarii. That is a muscle. If these are the two transverse processes, it attaches right there. It's an inch big. How did I even figure this one out? It was my college ice hockey players that kept coming in going, it really hurts in here, it really hurts in here. I'm like, what the hell are these guys doing that no one else is doing? Well, they're college hockey players and it's club, which means they sit all day on a crappy sofa and they lay like a mermaid, all right? Which means they're pinching one side and elongating the other. Then they're getting up and they're trying to skate and they've contracted this side and this side stretched. So I followed all the way in and put my thumb right there somewhere between L4 and L5 on that transverse process, and tears came to their eyes, and I went, I'll get them there. And they're like, you're pressing really hard. I said, I'm going to give you what you need, not what you want. And you're never going to find a doctor that loves you as much as I do. And they couldn't, you love us a little less, they asked. But that's the intertransversarii. You have to get deep. It gets confused with the QL because everybody runs for that one, but that's where it is. I also have some pictures in the slides because my attitude when I produce slides for you all to go back to is I don't want to have to make you Google the stuff that I would have wanted to Google if I was taking it. So you'll see those pictures. The lats are interesting because everybody forgets that the lat is a shoulder muscle. So all of these people blowing their rotator cuff are probably not firing their lats well. Because when you think of the lat, it comes up here and it attaches up here. Do you remember the muscle that you used to climb the ladder from school? It was the lat muscle, but we all tend to forget that when we get out and practice. So what we want to do when we're reaching up. However, you watch them reach up and they can't walk out. They're kind of like this. What's happening? The triceps and the lat meet right here. And they sit together like this. And then when they extend, they go like this and they form a tug of war right here. So you have to move one way and one the other way and break up the tug of war. That's one of the areas that's totally missed when people are treating the shoulder. Have them extend the arm, you stick it right at that interface and they'll be like, why have you never gone there? I said, oh, just had a hunch. Don't lie, you just learned it. Just had a hunch. All right? The pec minor is involved with scapular motion. Everybody goes after the pec major, they forget the minor underneath. That stuff you better know. I'm not going there. So here's your muscles. I highlighted a couple of them so you can see in there how tiny that muscle is for a little quick refresher. All right? So that's what you want to make sure you pick up on that intertransverse area. That's the diaphragm. So I want you to remember this. You learned it once, some of you didn't. I ate 10 eggs at noon. Does that sound familiar? I ate is the inferior vena cava, passes through the diaphragm at the 8th thoracic. 10 eggs. At T10, the esophagus passes through. At noon, the aorta passes through at T12. How many people that are having heart attacks or having gastric issues or having breathing problems? So aside from just going to the back and adjusting T8, 10, or 12, you need to get in there and reach up in there and start to pull this down. They will cry. That's okay. I cried the first time they did it to me. And then I went running 4 days later, and at the end of the run, I was like, oh my God, it's moving. It was so cool. When all of a sudden your diaphragm is open and you're not doing this, you're stunned at the difference. So that's something you want to take a look at. You can see looking up how it's dome-shaped. But you can also see looking up how low it attaches. It attaches down to L3 and almost L4. So that's going to be involved in some of their back pain too. So why they're having breathing problems there too. You're not going to mess up if you release the diaphragm. I had a case that was absolutely the freakiest case I've ever had. She had a spasming diaphragm. And I have the video somewhere on my phone. But she's laying on the table and her diaphragm literally looked like ocean waves going up. And I had never seen this before. And she goes, this is what it does sometimes as she's pale. And I was like, well, okay. So I just went in and released the diaphragm, and it took me about, I don't know, 30 seconds, and it stopped. She goes, no one's ever done that before. And I went, well, no one's ever given me this before. You know, something like that. There were other things with that case, so I didn't solve the problem. But it was a fascinating thing to work with. So they do walk into your office. Okay, so here's where I was saying, see how that lat comes all the way up into there? And it attaches up right in there. So you want to make sure you separate those two, like I already said. And that's why anything that I'm telling you, the asterisk is, so that's how you don't have to take a note to remember which one it was. All right, so the structures that need to be treated in the lower extremity for the golfer. The knee, the popliteus. The popliteus is a messed up muscle in skiers because they're pivoting, and it's messed up in golfers because they're pivoting. As they're coming into their backswing, they're putting a lot of stress on it, and as they follow through, they have to do it. So that's going to do that rotational move. You want to get right up into there. The posterior tib I only recently highlighted because something happened in my office. I was pretty sure this gal had a stress fracture. So I booted her for 2 weeks. And it wasn't actually a full stress fracture, it was an MTSS, a medial tibial stress syndrome, which is the new term for shin splints. So when they come in and tell you they have shin splints, your diagnosis is actually MTSS. All right? So just so we have no confusion on this, stress fractures typically occur down in the lower portion, the lower 2 inches. The stress syndrome will be up higher. All right? So if they're pointing down low, raise your index of suspicion for the stress fracture. But if they're pointing up high where the shin splint is, It's starting to thin in that area. So that's where you want to go. But if you dig into the posterior tib, you will find a band of tightness back there. I've done some dry needling in it, then I've taken my thumb with a little bit of lotion and just glide through, and you'll feel the area of restriction, and they'll start to well up, and they'll be like, oh my God, oh my God. But that's actually where it is. Start working in that area, give them the appropriate strength exercise, and you'll get them through. Now, you might still need to boot them for 2 weeks, and that's not a terrible thing. I have somebody training for Marine Corps Marathon, and she's having a meltdown. So I now have her running again, but after doing this for a couple of things, I now have her back up to 5 and 6 miles when she was running nothing. With the elbow, you want to take a look at the annular ligament. Again, when you're working with the golfers and they're starting to get that tendonitis, the annular ligament is what circles around the radial head. So you want to dig into that area and clean up some of that because they're not getting that motion through there. I can get into a whole thing on scapular stabilization, but again, this is just, we've got a short time. This is just in your soft tissue, what you need to start to treat. In the wrist, carpal ligaments, especially after they've had a fracture in there, this is going to be real tight. So you need to use some overpressure and start to dig in through there, or you can use your tools, however you want to get in there and work with their range of motion. Now I want you to take a look at something. If my range of motion is down, okay, what's happening is this area here has to elongate. But if they're saying the pain is on the bottom, you're sitting there thinking, well, that doesn't make sense because this has to elongate. Most people don't hurt themselves when their muscles are in contraction. They usually hurt them in elongation or eccentrication, which is a new word. Okay. But what's happening is, this came to me when when there was so much snow and I couldn't close the door. And I'm cleaning down at the door, trying to clean it. And my husband comes over, he goes, well, no wonder you can't close the door. The snow is built up on the hinge side. That's what's happening here. This can't get to its full range of motion because there's snow built up on the hinge side. So don't hesitate to look at the opposite side to find out why it elongates. Real quick story, so we're on the JetBlue plane and they couldn't close the door. And of course I'm sitting back in row 3 or 4 and I look at the attendant and I said, well, did anyone check the hinge side? She goes, we've got technicians on it. An hour and a half we sat there. Finally the pilot goes on, ladies and gentlemen, the technicians, our smart technicians, finally realized there was a problem with the hinge. All right, so golfers are plagued by knee pain. Is it really all about the knee, or is it a problem from the hip? If they're having knee pain, there's a problem with the hip, okay? Guaranteed. There might be a problem with the ankle, because when we look at what Mike Boyle said, he said that every joint in the body has a purpose. The ankle has to be mobile. The knee has to be stable. The hip has to be mobile. The low back stable, and the upper back mobile. And if any one of those joints changes its function, above it or below it will compensate. So if they come in with knee pain, look above. You can look below, but it's always going to be proximal also, okay? So up there we have some of those muscles highlighted, and sometimes the meniscus is stuck. So you might have to go in and loosen up the meniscus too. All right, elbow, wrist, those are some of the ligaments. The retinacula, that's what I was kind of showing you with this. The retinacula, keep in mind, is a little spider web that sits on top of those tendons. If we didn't have that retinacula, the tendons would all pop up. But the retinacula and the tendons will glue together. So you want to separate them from each other. So general advice for golf. You want to work on hip and thoracic mobility. The scorpion move, the Bretzel move, the rib roll. Perry Nicholson has a YouTube that it was in Dynamic Chiropractic a long time on the rib roll, and it really loosens up in your upper thoracic. So that one you might want to make a note of and put that one if you're not using it. Windmill squats I have a picture of. You want to strengthen the back line. Everybody always strengthens the sexy muscles. Nobody really goes to the back line and works on those. Lats, glutes, and hamstrings. You guys are sitting here right now just deactivating your hamstrings as you're listening. It's just a travesty, okay? So you need to be making sure you're doing some hamstring strengthening. Now, I said this at the ACBSP conference. I found out how much weight I need to lift so that I have no hamstring pain for a minimum of 4 days. And that is 155 pounds, 6 sets of 5. So if you're picking up 20-pound dumbbells and thinking you're going to really fire your hamstrings, you got to load them more. Okay? Your body has a capacity. You're decreasing your capacity as you sit. You've got to up the capacity so you can meet the load. Foundation, great book. Forget that the forward is by Lance Armstrong, but just put that over here. But the fact is, it's a good program, and it does really teach you some great things for strengthening the back line. And then scapular stabilizations. Anybody who has elbow, wrist, and shoulder pain needs to be doing scapular stabilization. So again, activate the core first. This is something that people are doing at the end of their workout. Everybody goes through the workout, they do all their cardio, they do all their strength, and then they lay on the floor and they do abs. Why do they do it that way? Because they just want to lay on the floor at the end, they're dead. But if you activated the core before the rest of your workout, you will be stunned at how much better your workout goes. And at our facility, we advocate strength before cardio. The reason we do that is because a lot of people do strength after the cardio and they're literally too exhausted and the muscles are wiped out. So if you keep it in that order where activate the core first, then do your strength, then you can go into other things. Stretching, hip mobility, and thoracic mobility. So this is the hip hinge. I would like to think everybody's familiar with the hip hinge, and I'm hoping some of you are at least, but some are not. And what I'm finding with the hip hinge is you all used to do it when you were 3. And then you went to kindergarten and you didn't do it as much. And some of your better athletes do it, and some people think they're doing it. Here's what I find with the hip hinge. He was pushing his butt back, but what happened was he wasn't pushing it back far enough. So we're going to talk to Ken for a minute and talk about the hip hinge, and I hope the audio is good on this.
Yeah, when you do one of these numbers, that's a problem. And we always say don't put fitness on top of dysfunction. The doc here, how can I get more mobile right away so I can be not being a dysfunctional movement?
Well, probably most of the time when people are starting to use their lumbars as the fulcrum instead of using their hips. You put your fingers here and you push your hips straight back, you start to get into the right position.
Okay.
So what we're going to do is we're going to pretend we're having a tug of war. So you're going to give me your fingers, and what I'm going to have you do is take your butt and start to drive it to the back wall as if you're being pulled out there by a string. So keep going, keep going, keep going, and see how I'm pulling you forward?
Yeah.
So what's ending up happening is we're getting you into the classic hip hinge. So that now you've got the tug of war happening between your butt and your knee. That's what we want. So go ahead and try that without me.
See how flat his back gets?
Perfect. That's what we're looking for. Good job. Okay.
So what we say is we say hinge at the hips, let your hands find the floor. So everybody get up. Now there should be enough room. If there's not, you might need to move it sideways or move to the halls. All right? And if those of you who have done yoga, the chair pose is in this area, but it's not exactly that. So take your fingers, put them right here at the hip tie-ins, and just keep pushing, 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 and just keep going. You can let your knees flex a little bit at this point, but you see how low you've come? And now let your hands drop. See how close you are to the ground at this point? So when these people come in and say, hey, can you touch? Come on up. So do it one more time, so make sure you have it, because you have to teach this to your patients. All right? This isn't just for you. I mean, I want you guys to do good things, but, you know, you're saving your patients' lives too. So that's your hip hinge. And you literally should feel like you're rocking a little bit back into your heels. You are still contacting your feet to the ground. All right? Because you want 3 points of contact on the bottom of your foot. You want the heel under the first and under the second. So that's where you're grounded with your hip all the way back. Make sense? Have a seat. We got more stuff to be standing for. So this is the windmill squat. All right? So this has 2 purposes. The beginning is either the praying or prying hip opener. All right? And the elbows are right inside the knees. We're in a deep squat. If you have an FAI issue, do not go into a deep squat. And if you have an FAI issue, so you can still do it a little bit, and press. So you can still get around it. Those are just the ones that are contraindicated to go past 90. So you start here. Now what you do is you drop one arm to the floor, and I am pushing open that knee while I rotate that up. While doing that, the force is being felt along this line. All right? So I know you're not warmed up. But go ahead, and if you don't have really tight jeans on, give it a try to get into this position. Now, the one thing is you're going to need to open up your feet wide enough to keep your heels on the ground. If you're coming up to the toes and the ball of your foot, your legs are probably too wide and you're not comfortable. If it's too deep of a squat, that's okay. Bail out a little bit, work your way into it. When you're doing it, like I said, you want to feel it here, but don't blow your back pushing it right now. Yeah. All right? But I want you to see this. The goal is to get the arms one above each other. Now, I'll be honest with you. This was taken before my shoulder surgery. That's why they're not up above each other. They are now. So this is a really funny thing about this. I've been doing this for about 2 years, and then I returned to golf. I overdrove the green on a par 4, and I was dead center fairway. And everyone's like, what the hell's going on with you? I had hip mobility. I had thoracic mobility. That is the dream of every golfer, to be in the fairway. And what happens is if you come back here and you end up over there, you're not coming around with that rotation. That's what that exercise can do for you. So it's a great one to give your golfers. All right, running injuries, hip and thigh, and then the stress fracture in the hip. I'm going to give you a little tidbit on that one, because we also see stress fractures in the lower leg. If you have a patient coming in with stress fractures in the lower leg, chances are good that it's a mechanical issue in their running gait. If they are coming in with stress fractures above the knee, it is a nutritional issue. Okay? And I still remember my one patient who had a stress fracture in the hip. She's like, but I eat kale. Like, yeah, kale doesn't cut it. Okay? I ate it yesterday by mistake. I do. I maintain a cilantro-free lifestyle, and I try to avoid kale too. But anyways, if they come in with recurring stress fractures, it is both mechanical and nutritional. And chances are, if it's female, they're going, what do you mean I have to have a cycle once a month? Yeah, I know, go crazy. All right, ankle and foot. So those are the typical things we're going to see in running injuries. So in the hip and thigh injuries, we're going to get all sort of hamstring stuff and glute medius. Everyone always gives the glute medius all the press, but the glute minimus gets neglected. Keep in mind the way they sit kind of like this. One's tucked underneath. So when you go to extend your leg out, it's going to be a TFL, a glute min, and a glute med. That one just keeps getting mistaken. And the TFL then just shuts down for the hell of it, because why should it do all the work? All right? And the inferior portion of the glute max. Do you guys remember the linea aspera? Do you remember what it does? It holds the attachment to the glute max. So how many people come in and they say, I Googled it, I have IT band syndrome. The reality is you do need to do an exam, because you're going to prove to them that they don't have IT band syndrome. It is the inferior portion of the glute max that you need to get in there and treat. And you'll be down on that, and they'll be like, yeah, it's my IT band. I'm like, no, your IT band is here. This is where I am. It's underneath. Because the deep stuff will manifest in the top stuff. Okay, so you always have to probably look a little deeper. So how do you remember all this? Just go back to your anatomy class and just start to run the layers. And think, how many layers? You got 6 layers in the back. You got 6 layers in the foot. Which one of those layers is doing it? Probably the deepest layer is doing all the damn work. That's why they're complaining. Somebody calls in sick to work, someone else is going to do the job. Someone calls in sick to work 30 days, the one doing the job is going to start to complain. That's what's going on with the body. All right? The proximal portion of the rec fem, everybody forgets. Everybody goes after the psoas. Psoas gets all the press. The iliacus is sitting there crunched all day. You're crunching them right now as you sit. And what are you doing to that proximal portion of the rec fem? Crunching it. So what happens is they get up and they walk like this. So they can't get any hip extension. And then they do it, oh, but that hurts. Yes. Yes, it hurts because you've just shortened the muscle and we need to elongate it again. So that's why we have to go in and treat that. The adductor magnus, the posterior portion, provides hip extension. So that's probably going to be involved in there too. Oh yeah, I know, but I hate to treat that on people that's sensitive. Hi, I need you to move everything that's in your pants to the right side. Okay? That's it. This is where I have to go if you want me to help you get better. They'll do it. And the sciatic nerve, we know that's there. Okay. So here's where you get to look at some of this stuff. This iliacus is sitting all the way up there. Look at these attachments. All the way up through there and the pectineus. I talked about ice hockey players and groin pulls yesterday. You've got to get into the obturator externus and the pectineus. And they sit kind of like this, right in that fossa. Obviously, you got to stay off the femoral nerve. That's a bad thing. Something's pulsing. Don't sit on it. Okay? I hear that's bad. But the reality is you're going to need to just get in there and start to work it. All right? And again, those are the proximal attachments. Double checking something. It goes through at proximal and distal attachments. So when we were in fascial distortion, Casey said some things about as you sit on your ischial tuberosity, the tendon is supposed to act like an ice cube. It is supposed to be rock hard, acting more like a bony component. When you get up to start running, it is supposed to act like water. And it is supposed to just let you glide. So technically, the tendon needs to kind of sit in a slushy state so that it can adapt to whatever temperature you're giving it. Circulation running, not circulation cold. What happens at that proximal ischial tuberosity when you pull it and damage it is it stays stuck in ice. And you have to melt that ice. So you have to get in and really pressure it. No different than if I kind of put my thumb on an ice cube. I have to go in, release, go in, release, go in, release. However, I don't just go in one direction because I'm not sure if it did it this way. Maybe it did it this way. Maybe it did it this way. So I have to do that. So I had said yesterday in ethics where I had to treat a guy, I had him over like this. I'm on my knee pressing up into the ischial tuberosity, trying to work it and pressure it from different angles. I had him going up and down with weights because it started by him just laying on the table, me working it. Next visit, laying on the table another way, me working it. Sideline, face down, face up. You've got to move him in different positions. Don't just go with what you learned because they'll tell you when you're on it. And then what I ended up doing was I said, okay, now let's test it in motion. So he would get up and squat. He's like, okay, it's there when I do this. Okay, we did that. Then we started to add weight. And we started to add some of the factor principles that you can go into doing. You don't need to use your thumb. You can use your tools. You can use your needles, whatever you need to do. But you need to think as to how do I get to it from other directions. I've seen a lot of these, and why have I seen a lot of these? Because I had one. And God has this uncanny way of giving me things that piss me off, so I figure out how to treat them so that then all these other people can come in with the same thing. I don't know. It's my call. It's annoying. It hurts them. All right. The articularis genu. A friend of mine accused me of making up this muscle. I did not. It really does exist, and I double-checked with an orthopedic surgeon. I already covered popliteus and posterior tib. Where the hell is the articularis genu? It sits right up here, underneath the quads. So everybody comes in with PFPS, patellofemoral pain syndrome, and 9 times out of 10, the articularis genu is just pissed and short. So anyways, that's what ends up happening. So you have to get into this area in pain, or knee pain. You always say first, did you check your shoes? Oh, they're new shoes, oh, they're old shoes, okay. Oh yeah, I know, I gotta change my shoes out. So what you do is you have them write the date of the shoe right here. in a black or a pink or whatever color Sharpie. That way when they start to have pains, they go, oh yeah, it is time to change those things out. And that way they don't have to wonder when they bought it or when they started using it. There are recovery exercises that I came up with that I'm going to cover. And you want to, again, strengthen the glutes, the hams, and the adductors. I lost my...
Yeah, well,
Oh, well. All right. Now you got my voice, sorry. All right, and we're going to talk about the belly maneuvers. All right, so this is me when I have nothing to do at the airport and my flight is delayed. All right? So I just sat down and I just started watching people walk. And you'll see every cycle. So they deserve the knee pain because they're doing this little shuffle thing which can't get them into hip extension, and their toes, the shoe's going to fall off, so they are gripping with their toes. So anybody that comes in with low back pain, hip, knee, foot, get rid of the flip-flops first. Hi, honey, I need to go buy shoes. Okay? That's the most important lesson. I could do a whole lecture on flip-flops. But the belly maneuver is what I want to cover with you because this is a very, very important maneuver. The number one reason that older people fall is what? Exactly. Everyone says balance. Everybody says core. It is toe push-off. So everybody stand up. Now just stand, and I want you to kind of rock back into your heel and feel what happens with your toes. See how they all flare? Everybody rock forward into the ball of your foot. See what your toes just did? They just grabbed the ground. All right? Now, I go to church every Sunday, and communion is the saddest part of the Mass to me because I know it's awful. Because I can't. They go to walk forward, they don't have their toes to catch them, they're down. So, you're going to teach your patients the belly maneuver, not because I said, and not because I'm going to come to the office and stalk you. It's because it's the right thing to do. So, to do the belly maneuver, you're going to come, I'm going to show you this, and then we're going to go to the walls. You need to be near a wall, because if they're going to fall, you want them to catch themselves on the wall. All right? You're about a foot away. All right? You'll find the right spot for everybody. As you lean in, you don't want your heels to come off the ground. You want your toes to feel the push into the ground, but you don't want to heels up. You don't want to bend your knees, and you just lean forward and come back. I have a patient, I've been training her for about a year now. She can hold this position for 3 minutes. It is absolutely incredible, and she's 64 years old. All right, so come on, grab around the walls, and let's give this a shot. There's room up here too. And like I said, with the notes, you'll actually have the direction. So arms are up, keep them at neutral. Your body is absolutely straight. And now just kind of lean forward. Do not lock your knees or just don't bend them. And try to keep your heels on the ground and hold for 3 seconds and release. The trick is for the hands not to be on the wall, but they're there if you're going to fall. So lean in, 2, 3, release. Again, lean in, 2, 3, release. Now let's try it with breathing. Everybody, because nobody's breathing. You're all holding your breath. Okay, so inhale, and now lean in, and exhale, 2, 3, release. Okay, have a seat. That was great. I look around and see everybody's shoulders tight. Let's go back to the diaphragm. Okay. So, step-ups are an exercise that I started doing in 1990. So when people are going upstairs and they're telling you their knees hurt, a step is 7 inches. 2 steps are 14. I tell them all that I want you to take 2 steps at once. This way you can do your rehab during the day. You don't have to just go and do step-ups. But what ends up happening is when this is parallel to the ground, the glute fires. When the knee is when the knee is below, the knee fires. So all these people complaining of knee pain, it's because their glutes are gone. I do a seminar called How to Build a Butt, and this is one of our exercises. So you say, okay, well my foot doesn't always fit on this step. This is accurate, especially for the men. okay? There's not enough room. So what you do is catch the corner of the step with your heel. If you fire through the heel, you're going to get the glute to fire. That's really what the trick is. If you fire through the ball of the foot, the knee's going to take the brunt. So I call it the two-step climb, and they all get a PowerPoint. Well, all my patients get a PowerPoint with the exercises for them. But the two-step climb is just verbiage going, take 2 steps at once unless you're wearing a pencil skirt. Can't do it in a pencil skirt, I tried. All right? So that's it, and you can't really do it in heels. You kind of need to be in flats. So that's what the step up is for, and it is a fantastic recovery exercise for runners. Because after they've done their run, what I have them do in their last 200 yards is I have them sidestep. Okay, they have just pummeled their hips forward with the piston action going up and down. Now I got to build the other way. Why? The hip has 6 movement directions and the knee has 4. Okay, we've got forward, backwards, inside, outside, and then the hip has clockwise, counterclockwise. So what ends up happening is I've just pummeled them forward for 3 or 4 miles. I got to teach some of the other guys to wake up. So I have them sidestep for 30 seconds, flip to the other side, sidestep back and forth as part of their cool down. And then I'll have them find a bench or a stone wall or a tree stump, something that's in that vicinity that they can then do 8 on each side, twice of this, and it sort of reactivates their glutes after they're done running. These are the hip hurdles, and this is basically bringing it up and then bringing it back. Hockey players like to just go in one direction. You want to go in both. Hockey players, their hips, we're not going there. That's another symbol. All right, so, and this is one I want you guys to learn, but we don't have room, so you might have to figure out if you can find the room to do it. So let's see what this one is, because this is very important for the most important rule of all. Because if you have children now, you play on the floor with them. If you have grandchildren, you play on the floor with them. But if you don't have either, and you might, you're still going to end up on the floor at some point. And you're going to need to get up. All right? So if you can't get up the floor, how do you teach your patients to get off the floor? So this is a really great hip mobility. 1, 2, up. 1, 2. So basically what we're doing is, we're facing one way, we lift our knees to the sky, drop them to the other, and push up with the glutes. And that's what I'd like you to try. I think we have, 4 minutes. And, and I'll be done in a minute. So we can space that out. So let me finish this out, and then you all can try that, and I'll go back to the slide. All right, finishing touches. You can tape them to secure some of the stuff you've done. Sometimes it gives them a little confidence. Sometimes it's really because they need it. What's the purpose of tape? In a nutshell, if I bang my hand on something, I'm going to do one of 3 things. I'm going to shake it, I'm going to rub it, or I'm going to hold pressure on it. Tape holds pressure on it. It's just to activate the nerve cells under the skin, send a message up to the brain that says, whoa, stop this. Sensory gating is another somewhere. All right? All right. That's what I have. Why don't you guys give this a try, and then we'll close out. I'll show it to you again. There's room up. All right, so see how the knees then go up to the sky, and then they flip to the other direction. Why do I keep doing it that way? So, knees in one direction, flip up to the sky, go to the others, and then push up to the glutes. There you go. You will also, unfortunately, find one side works better than the other. All right? But that's a really great hip mobility exercise. Anybody have any questions? Because we're wrapping up. So if you have them, now's your chance, or come up later, or avoid me like the plague. Thank you all for your attention.